Awesome. Thank you guys and girls, women, for attending case reviews for March. We've got 4 cases as usual and kind of highlighting some of our shout outs from the hospital in these cases as well, in half of them. So as usual, this information is confidential and privileged. It's protected by HIPAA, and sharing it is strictly prohibited outside of this learning environment and amongst your colleagues is okay. So moving forward with case 1, this is a case of a 58-year-old female. EMS was called for possible stroke, and they found this woman sitting in the shower, visibly distraught or visibly not okay. They were told that she developed a headache, and when they found her, the patient was awake. She was very anxious. Occasionally, her speech was slurred, and her airway was open. She was protecting it, and she was otherwise pink, warm, and dry with no signs of bleeding. Vital signs were obtained 4 minutes after patient contact. Heart rate was not obtained, but blood pressure was at 135/66. Respiratory rate of 20, GCS of 15, and room air sats of 98%. The past medical history provided to EMS was that she has a history of GERD, hypertension, and heart failure, and that the story that they were given was that 20 minutes prior to initiating 911, while she was in the shower, she developed a sudden onset of a severe headache, slurred speech, difficulty with her balance, and she felt short of breath as well. This was in the morning at 9:41. A BFAST and a LAMS were obtained. She was positive for balance and for speech. Her LAM score was 0. At 4 minutes, those were the vital signs that I just reported to you that were essentially normal. Additional narrative documentation was that her bilateral legs were swollen, and that was in the last 12 hours, and that she acknowledged that she missed a few doses of her medications, which would include also diuretics. At 7 minutes, they did another set of vital signs, getting the heart rate of 96, SpO2 of 100, and a 12-lead EKG. They repeated the 12-lead. It was largely unremarkable, so I didn't include it in here. And they noted that she was very ataxic when they ambulated her. At 9 minutes, they repeated another set of vital signs, omitting the heart rate, blood pressure 125/80, respiratory rate of 22, GCS of 15, SpO2 of 99 on room air, and her blood glucose was 146 milligrams per deciliter. The patient was reporting feeling nauseated and that both of her eyes were affected with blurred vision. They initiated transport at 18 minutes. At 19 minutes, they attempted an IV, which was unsuccessful. They attempted another one at 21 minutes, also unsuccessful. They notified Peace Health that she was going to be a stroke alert. And at 24 minutes, they repeated another set of vital signs, but without a heart rate or respiratory rate, noting that her blood pressure is 139/94, SpO2 of 68%. An IV was established at 25 minutes. It's unclear if this was a spurious respiratory hypoxia or if this was actual. They didn't document that they put her on oxygen, so it's not clear if they felt that this was accurate. And of course, if you find that the vital signs that are auto-generated from your monitor is inaccurate, put something in the narrative that states that you didn't believe it or that it was inaccurate, or don't record it and state that there was difficulties in obtaining X and therefore this was not recorded. So at 35 minutes, they repeat another set of vital signs. She's still hypoxic, but not as hypoxic as previous, with a SAT of 87%, no respiratory rate or heart rate recorded, and blood pressure is largely unchanged. The patient did complain of chest tightness about spatially the same time as the hypoxia was reported according to the documentation. And then at 37 minutes, they repeated another 12 lead and arrived at the hospital at 39 minutes. So in reviewing this case, which this was a case where Peace Health had gave a shout out to EMS for a job well done. So This was overall rapid neurological exam and cardiac exam with serial EKGs, complete vital signs, eventually not all at the same time, blood glucose check, past medical history, and the time on scene was great with less than 20 minutes on scene. Areas for improvement, just reviewing this case to set up for a presentation, is that a single heart rate was recorded throughout the entire duration of this patient contact, and then 2 respiratory rates were recorded, but not any associated with the hypoxia, and unclear if the hypoxia was real or not. So in the emergency room, the physician evaluated her immediately because she was a stroke alert. They noted that her stroke scale was 0. They didn't upgrade her, and as they were waiting for her workup, so just for knowledge of those listeners, here is that just because we don't upgrade these patients when you guys arrive, it doesn't mean that they don't get the neuro workup. They don't necessarily get the immediate consultation with neurology or the all of the images that would be appropriate for a stroke, devastating stroke presentation. So this patient still got a neuro workup, but just not an upgrade initially. So her labs were significant for meth positive in her urine drug screen, and then her BNP, which is a marker for heart failure, was significantly elevated at greater than 5,000. They did do a CT angio head neck as well as a CT head. The CT head didn't show any bleeding. The CT angio did show an occlusion at the distal basilar artery and the proximal posterior cerebral artery. At this read on the CTA occurred at like 88 minutes. The physician reevaluated the patient 2 minutes after the result came back from the CT angio and found that she was less responsive. The documented stroke scale at that point was 25, so markedly worse from 0 to 25, and that she was noted to have a dysconjugate gaze at that point. Neurology was consulted at that time, notified about the CTA findings as well as the patient's current status, and they agreed that she should be a candidate for TPA, although this was not initial. This was about 2 hours after she arrived. Because of her worsening neurological status and the likelihood of getting a thrombectomy, she was intubated for airway protection, and she went to the angio suite for a thrombectomy with neurosurgery. During the hospital, she was extubated on hospital day 1. She was treated for acute and chronic heart failure from non-compliance and probably meth exacerbation of her, leading to her heart failure. And then she also had aspiration pneumonia, for which she received antibiotics. She was discharged on hospital day number 7. So another example of how our patients evolve, the importance of serial reassessments and high index of suspicion, which EMS appropriately identified with the BFAST, and getting her as quickly as to the hospital with the right interventions, leading to her being within the time frame for TPA despite not giving it immediately because of her waxing and waning improvement. So presenting this as a basilar artery stroke, the anatomy, which is this picture up here in the upper right side. So for the cerebellum, we talk about middle cerebral artery when we talk about like the Cincinnati score. So that's when we're identifying occlusions or ischemia related to MCA strokes. As you go from anterior to, I guess you could say, posterior, but more like the back of your head, you're talking about the confluence at the basilar artery right here, which supplies the midbrain, which you've got the pons and the medulla oblongata. So a stroke to this area impairs blood flow to the posterior circulation. You may have heard of posterior circulation being difficult to identify, which is true. And then also if there's ischemia and potentially swelling either from hemorrhagic conversion or just ischemia to the brain tissue, it's a small cavity that may need to be decompressed. So these are patients that may need surgical intervention as well. And then you may have also heard of like the condition called locked-in syndrome, where the patient is alert, but they can't talk or move. So these are all related to basilar artery strokes. So the causes can be large vessel occlusion, atherosclerosis, or dissection, dissecting up into the intracranial, likely more like subarachnoid. And then the clinical presentation has a very varied presentation. So mild might be just nausea, confusion, headache, dizziness. And then severe would be they can't speak, they can't talk, they can't swallow. They might complain of paralysis, hemi or quadriplegia. They may pass out. They may be in a comatose state. There may be cranial nerve abnormalities, and they may complain of cardiac or respiratory abnormalities in addition. So these are patients that can be very difficult to assess, especially if they're just complaining of nausea, confusion, or syncope, which could also explain the, it could also be the symptoms related to a basilar artery stroke or a cardiac event. So diagnosis for this, other than suspicion, to initiate the appropriate workup would be a CT head, a CT angiogram looking at the blood vessels of the head and neck, and then if the CT angio wasn't available, which isn't usually the case at our hospitals, both at Legacy Salmon Creek or Peace Health, but occasionally if we have CT problems, an MRI angiogram would be the alternate imaging study. Treatment is going to be anticoagulation, TPA, or tenecteplase. At Peace Health, we've switched to tenecteplase. Really doesn't make too much of a difference pre-hospitally, but just that we may be hearing people say, go ahead and give tenecteplase, which is synonymous for TPA at Peace Health. And then they may be candidates for mechanical thrombectomy if there is a large vessel occlusion. Oh, and I guess the criteria met is less than 4 hours. They don't have they aren't currently bleeding in their brain. They don't have any contraindications. There's actually quite a long list that we review before we consider thrombolysis to patients. And then as for our pre-hospital protocol, I thought the most appropriate for this patient's presentation would be the stroke protocol. So as a reminder that you're going to be assessing for altered mental status as potential etiology for a stroke-like presentation by checking a blood glucose, checking a BFAST, and documenting any abnormalities or documenting that you couldn't perform a BFAST. A LAM score, and if bleeding suspected, you want to maintain ventilation rates between, or actually at end-tidal values of 35 millimeters of mercury. You're going to titrate oxygen between 94 and 98%. And recognize that just because the patient may not be communicating with you verbally doesn't mean that they can't hear or be aware of what's going on. So be conscientious about what you're discussing or how you're discussing it. And then criteria for going to Peace Health, actually criteria to going to any hospital emergently for a possible stroke is any patient that's had BFAST findings that have occurred with less than 24 hours. So even if they have resolved, if the patient has critical findings such as they're comatose, they can't speak, or they're having profound paralysis, and you want to notify the hospital about the potential for a possible code red stroke alert, as we are going away from code 3. And then they will potentially go to Peace Health if their LAM score is 4 or 5, so greater than 4 or 5. Make sure that they have the ability to take you. So that means that these are patients that we're worried about that might have a large vessel occlusion. So if our calendar for neurointerventional shows that they don't have coverage, then that wouldn't be appropriate to take that patient. And it should be on HOSCAP or been notified when you start at the start of your shift. And then you'll want to take them to the most appropriate other if Peace Health is not available. So that might be Manual, Providence, Portland, Kaiser, Sunnyside, or OHSU. And you can always contact medical control if you're not sure. But these are patients that are also any patient over the age of 80 and symptoms that have been present for more than 3 hours, so putting them likely outside of TPA, or thrombolytic therapy, but they've been less than 24 hours. And then if you suspect any kind of bleeding in the brain for these patients, they should go to Peace Health, and any signs of profound presentations such as comatose aphasia or paralysis. I think that's about it. I'm just looking to see if there's any questions. Nope. Or thoughts about that. Does anybody that's on want to provide any additional questions or thoughts or insight? All right. Case 2 is a case of a 71-year-old male. EMS was called for near syncope, and they found the patient laying in bed looking poorly. The patient had stated that he felt like he was going to pass out. He felt like he was going to die. Vital signs were obtained prior to arrival by the first responding fire agency, noted to have a heart rate of 30 and a blood pressure of 54/30. The patient was awake. His airway was open. He was protecting it, but they noted that he was very pale, diaphoretic, and overall weak radial pulse and bradycardic. There was no signs of active bleeding in the past medical history that the patient was able to provide. It was that he had a history of hyperlipidemia and enlarged prostate. The patient had stated that he was laying in bed when he had a sudden onset of lightheadedness, and he feels like he's going to die. So vital signs obtained by first responding agency in the very, very top. Those of you that potentially are listening to this without the visual, I'm going to talk about the minutes because there's a lot of things going on here. So this patient contact was at midnight. At 4 minutes, they were unsuccessful in getting an IV ×3, and they did get a 12 lead. The 12 lead shows very slow QRS, which looks wide and complex. And you could say that this is artifact, but if you march out the P waves, there are multiple extra P waves for QRSs. If you draw your attention to the precordial leads, let's say V3, you can see there's 1, 2, 3, 4, 5, 6 P waves for every QRS. So for all intents and purposes, this would be diagnosed as third-degree heart block. The life pack shows that it's AFib with PVCs, so the importance of not just reading what the monitor spits out, but your own interpretation of it as well. So at 10 minutes, they place the patient on 3 liters nasal cannula. At 11 minutes, they repeat the EKG, which is essentially the same. Very slow, wide complex, multiple P waves outside of the QRSs, and still read as AFib with slow ventricular rate with PVCs. At 20 minutes, they repeat another set of vital signs, noted that the patient was bradycardic at 48. His heart rate was, or his blood pressure was 123/73. His respiratory rate is 20. His GCS is documented as 15, and his SpO2 is 100. At 23 minutes, an IO was placed, and they started to pace him at 80 beats per minute at 80 milliamps. At 24 minutes, his heart rate was documented as 80. His blood pressure was 134/40. His respiratory rate is 20, GCS of 15, SpO2 of 100, and a 12 lead was repeated, which I didn't put in here because it's the same. But a little bit faster, I guess. At 25 minutes, they initiate transport to the hospital. At 30 minutes, they give this patient 5 milligrams of Versed, assuming that this was for tolerating the transcutaneous pacemaking. And at 38 minutes, they give him 200 milligrams of ketamine. They bag him, and then they attempt intubation. From what they documented, they stated that the patient became unresponsive after getting the Versed, and he still had a pulse, but they decided to RSI him, but they RSI'd him without paralytics. At 42 minutes, they attempt a video laryngoscopy. They were successful on first pass intubation, And at 43 minutes, his heart rate's 75, his blood pressure's 138/84, his respiratory rate's documented as 12, GCS of 3, SpO2 of 94%. At 44 minutes, I believe that the next two drugs were for post-intubation. So 2.5 milligrams of Versed at 45 minutes. He was given 100 micrograms of fentanyl. And at 47 minutes, he had another set of vital signs noted to have a heart rate of 86, a blood pressure of 82/51, a respiratory rate of 13, GCS of 3, and an end tidal of 23. At 50 minutes, they repeated an EKG. He now was in asystole. They initiated CPR. They continued CPR at 53 minutes, and they document, I believe this is ROSC because he is a blood pressure, but a heart rate of 0, a blood pressure 100/40, respiratory rate of 24, GCS of 3, and end tidal of 21. He was at 55 minutes, an IO was placed, a second one, and at 60 minutes, a third line was placed. And then he was arrived at the hospital. This case I'm presenting because there was a couple of things in here that I think we could have done better in general, but just looking through this, you can see that it took about 23 minutes after the transporting agency arrived to treat his third-degree heart block. The initial responding agency had basically described very symptomatic bradycardia, and remembering that we don't just sedate, we also paralyze when we're talking about RSI. And although the interval from intubation is appropriate, the patient did not receive pain management post-intubation sedation over benzos. And we recommend ketamine unless ketamine is not available. So in looking over this case, they got a 12 lead pretty early on, which is great and very much indicated. An IV was attempted early on, and that they were able to intubate the patient on first pass using video laryngoscopy. So those are some great components of the patient's care. The areas that we could improve on, I touched briefly on the previous slide, but really the vital signs weren't obtained by the transporting agency again until 20 minutes after patient contact. Unstable bradycardia management. Anybody on this call here have a thought about how they would manage this bradycardic patient? You can put it in the chat. I won't call you out as in if it's good or bad or whatever. Would anybody just start pacing him right away? Or would you have gotten atropine? I'm assuming that nobody wants to put themselves out there, which is fine. And then
I probably would have given atropine as I was setting up to pace, knowing that the atropine probably won't work.
Absolutely. Thank you, Dr. Mock, for commenting on that. Yeah. So just as an idea, we'll talk about this further after the patient follow-up too, about management. And then an IO should have been placed earlier. So although we had a couple missed attempts at IV access, we didn't go ahead and drop an IO on this patient until 23 minutes later. And then the recognition of transcutaneous pacing, sedation adjustment, especially in the critically ill or the elderly patient, potentially decreasing the dose into half dose. And then unclear if the milliamps were increased because the documentation was that multiple attempts were made at pacing this patient, but ultimately they felt that it wasn't capturing quite often. So making sure that it's clear in your documentation, either under your procedures or in your narrative, that you've actually increased the milliamps to try to have not only electrical but mechanical capture as well. And then pre-intubation vital signs, they weren't obtained. If the reason why we're intubating this patient is just to ensure that their airway is protected because either they have clinically declined or we have caused them to clinically become comatose, we should be getting another set of vital signs if that patient isn't crashing to ensure that their vital signs are optimized. We don't need to give fluids or pressors before intubation. And then remembering asystolic arrest. This patient was found to be an asystolic arrest, but I guess you can think of it as potentially this patient should have been given epi at this onset, but if they did a pulse check 2 minutes later and they found that they got ROSC, just make sure your heart rate indicates that you did get ROSC, then I guess epi could be withheld at that point. So in the emergency room, they were able to get ROSC. So I think the patient was actually still coding from the way that documentation was, is that they got ROSC after the patient was resuscitated upon EMS arrival, in that he rearrested multiple times in the emergency room, regaining pulses after short periods of CPR. They noted that his P waves were without QRS complexes, so they felt that he was a third-degree heart block without ventricular escape rhythm. He was started on an epidrip following one of his ROSCs. Cardiology was consulted emergently, and he was taken to the cath lab for a transvenous pacer. He had his dual chamber pacemaker defibrillator placed, and he was discharged home on hospital day 3 with a full recovery. So great outcome, despite some areas of improvement for symptomatic bradycardia. So third-degree heart block, this is AV dissociation, or you can think of it as intrinsic pacemaker failure. So the SA node is not speaking to the ventricle or the AV node to allow for ventricular conduction. So there's dissociation. This could be from chronic cardiac disease, such as heart failure, MI, hypertensive issues, or idiopathic fibrosis, or it could be also electrolyte related infectious disease such as Lyme's disease or endocarditis, or postoperative after heart surgery like aortic valve replacement, or medication toxicity. Medication toxicity, does anybody have any ideas that might clue you into a potential reversible cause of third-degree heart block from toxicity? I guess another hint, some people say they have some patients may say that they feel like there's a halo in their vision, or it's a cardiac med. And if you were thinking, because it's not in the chat, digoxin, then that would be a good guess. Or systemic disease, such as sarcoidosis or lupus, other autoimmune problems. It's a heart block is not that rare, but third-degree heart block is pretty rare from the data. We expect to see it in 0.04% of the population. So if you identify this in your career, recognizing that it's not very common. And then the clinical presentation could be that the patient feels like they might pass out, or they actually did pass out. They may be complaining of fatigue. They can have chest pain, shortness of breath, or they can be altered or obtunded. So as for the management, atropine is recommended for ACLS for bradycardia, with the caveat is that the atropine works at the SA node, and if there is third-degree heart block, there is dissociation at the, if I said the AV node, I meant to say the AV node if I didn't say that already. So if there's dissociation between the atria and the ventricles at the AV node, then atropine will likely not work. Other options could be epinephrine, which is in our protocol, or dopamine, which we do not have, and then transcutaneous pacemaking. If the transcutaneous pacemaking doesn't effectively manage the patient's hemodynamics, then they may be in need for emergent transvenous pacing. And then if there's reversible causes for this patient's third-degree heart block, such as an MI, or Lyme's disease, or endocarditis, or DIG toxicity, treat that overall as the definitive management. So in our protocols, bradycardia is the one I found that I felt would be most effective in discussing here. So obtain a 12 lead, observe and monitor. If there's signs of poor perfusion, so you think that this patient is symptomatic bradycardia, they're either altered evidence of heart failure, hypotension, or shocky, you want to try atropine, 1 milligram repeated every 2 to 5 minutes as needed for a max of 3. And if there's no response to atropine, you can start an epi drip, starting at 2 micrograms per minute IV, and increase 2 micrograms every 1 minute until clinical titration is achieved, clinical optimization for titration is achieved, and then transcutaneous pacing. Usually this is a treatment for symptomatic third-degree heart block or high-degree heart block, and do not delay pacing if IV access is difficult. So this is something that could have happened for this patient early on prior to attempting multiple IV attempts. And then you can sedate them as needed, so not necessarily absolutely needs to be done, especially if your patient is critically ill. You can manage their hemodynamics and then deal with their toleration of the transcutaneous pacing. And they also would be a candidate for fentanyl. So this patient received 5 milligrams of Versed, which is not the recommendation from our protocols. It's 2.5 IV. And then if you're having problems with capture, besides increasing the milliamps, you can try repositioning the pads. So any questions, thoughts, additional pointers?
I just have a couple of thoughts. I mean, I recognize that there's, there are areas for improvement, but I don't want to lose sight of the fact that, the crew got this patient to the, to the place where they could have the definitive treatment and the patient had a good outcome because of what the crew did. That's, I agree completely with what you said about the areas for improvement. Just one way to think about the epi is that in a case like this, you're likely having a third degree heart block because you're having coronary ischemia. And so by giving that epi, by increasing your diastolic pressure, you're likely to increase coronary perfusion. And so you then increase your chance of getting mechanical capture when you do get to the transcutaneous pacing. It's unlikely that epi will fix this by itself, but it's likely to make you more successful with the transcutaneous pacing. And then the last thought I have is that I just want to explain why we want to use paralytics for the intubation. The reason we don't do ketamine only intubation is that you have a higher chance of first pass success if you get that skeletal muscle relaxation. I think hyper K is in the differential for this patient. So I think it would be totally reasonable to use rock for this patient, but you're gonna increase your odds of first pass success if you relax the skeletal muscle. But again, just coming back to the big picture, got the patient to the place where they needed to be and in a place that they were able to be resuscitated.
Yeah, absolutely. Thank you. All right, case 3 is a case of a 39-year-old female who was found on the couch, unconscious. EMS got called for unresponsiveness. Vital signs were obtained prior to transporting agency's arrival. Heart rate of 64, blood pressure 136/79, respiratory rate of 11, and a GCS documented of 8, blood glucose of 144, and her weight was documented as 70 kilos. She was found unresponsive. Her airway was open, and she was breathing adequately. Her skin was pink, warm, and dry with no evidence of bleeding, and her past medical history included hypothyroid and arthritis. The history provided, it sounds like, was from mom and sister on scene, who said that she had neck pain 2 days prior without any inciting events, and that they believe she was unconscious for some period of time, but something less than 3 hours. In addition to the vital signs being obtained prior to transport agency's arrival, an IV was established. Her blood glucose was 144. She was given 2 milligrams of Narcan because of concern for pinpoint pupils. A 12 lead was obtained, which is here, and then the patient also received 4 milligrams of Zofran. Interpret that as a sinus rhythm. This occurred at 5:48 in the morning. At 6 minutes, online medical control was contacted because the family felt that the patient should not go to Peace Health. They should go to Legacy Salmon Creek. They document that they were unable to perform a beef fast or a lambs. So in that online medical control conversation, the patient was essentially just an unresponsive patient that had complained of some neck pain prior. So they went ahead and approved transport to Legacy Salmon Creek. Transport was initiated at 12 minutes. At 15 minutes, another set of vital signs were obtained from the first ones prior to their arrival. Heart rate 57, blood pressure 130/86. No respiratory rate recorded. Oh, actually, respiratory rate of 15 and a GCS of 8. And at 20 minutes, she arrived at the hospital. So just looking, and I think Dr. Mock, feel free to, since this was a shout out to EMS as well, if you want to go over, I can go over the QA discussion if you want to go over, or whatever you prefer. I don't know if you're familiar with their charting before this presentation.
Yeah. No, I mean, did look over the chart. I mean, I think that this was handled appropriately by the crew. You know, protocol would direct this patient to Peace Health Southwest, because, sudden presentation, unresponsiveness, LVO is definitely a possibility. But I think and it sounds like there was some vigorous disagreement with the family on scene. And so I think the crew appropriately contacted medical control. And, the point that I just make is that this is a different situation than like penetrating trauma to the chest, where 100% of those patients are going to get transferred from Salmon Creek. This patient has maybe a 10% chance of getting transferred from Legacy Salmon Creek. So contacting online medical control to work through that is the appropriate way to go.
Absolutely. And the only things I put in there for areas of improvement is that the timeline was she was unresponsive for some period of 3 hours. So trying to narrow that down for us is super helpful, especially if we're considering a time sensitive intervention. And then the reason why I have BFAST and LAMS in there is that they had stated the patient was unresponsive. So I have a question out to our EMS leadership is I feel like we should still document in the procedures BFAST and LAMS, even if we can't report a value, but that may not bar out as something that we need to have in our procedures. So Dr. Mock, would you like to do the patient follow-up?
Sure. So in the emergency department, she had a non-con CT head, she had a CTA. There was a right posterior pica artery, CVA, and then also right vertebral artery dissection. With the timeline, she was not a candidate for TPA or endovascular. She was stayed comatose in the emergency department, was intubated, started on aspirin and Plavix. The last I emailed to you is the MRI was pending. Ultimately, did show a CVA. There was a question about whether this patient had meningitis because she had the neck pain and comatose, but there's no fever, no infectious symptoms, and we had another explanation for what was going on. So patient never got an LP, but she's ultimately doing well and getting close to discharge.
Thank you. Sorry to put you on the spot, but I thought you might know a little more details than I did. Awesome.
No problem.
So I was going to talk a little bit about vertebral artery dissections. As for the cause of ischemic strokes, it's pretty rare. It's less than 2% of the causes, but it's common in young people that are having a stroke. So up to 20% of people under the age of 45 potentially are having a stroke because of vertebral artery dissection. These can occur spontaneously, but they can also occur due to mild trauma. So these might be someone who sneezed, they coughed, they twisted their neck, or they were having chiropractic manipulation. In that the carotid dissections are more common than the vertebral dissections. The clinical presentation will be acute. They'll have either neck or back pain on one side. I'm not sure if at any point that there was discussed, does she have right or left side neck pain? But according to the information I found researching this, is that they usually have unilateral. 70% will have some neurological symptoms, so that makes it means that it's a high probability for a neuro complaint, but not necessarily in your typical large middle cerebral artery distribution. So they may complain of dizziness, ataxia, one-sided hearing loss, difficulty with swallowing, dysarthria, or complaints of vision changes such as double vision diplopia. What I was able to find too was that when these occur due to traumatic causes, so like a transverse process fracture of the spine, that they typically go on asymptomatic, but when they occur from a spontaneous presentation, well, I guess when they described as that as a traumatic presentation, that there might be a complete occlusion of the vertebral artery, and that those acute complete occlusions can be asymptomatic. But when there's a dissection or some flow allowed to go past, either waxing and waning in intensity, they're more symptomatic. So just curious. Anyways, the diagnosis for this condition is a CT angiogram of the head neck or an MRI angiogram, and the prognosis usually is pretty good. So up to 10% will potentially pass away, but it's usually very, very abrupt symptoms, abrupt onset, and more associated with intracranial vertebral artery dissection. So they describe it as being substantial subarachnoid hemorrhage, where extracranial dissections have a higher probability for complete for lower mortality and for full recovery. So 80% of the patients with vertebral artery dissections will make a full recovery. And then the treatment is mostly preventative, so preventing stroke with anticoagulation. From what I was reading, could be heparin, could be aspirin, and yeah. And then this here, just to remind you, so we talked about basilar artery stroke in the first case, and then as that goes down further along the spine, these are your vertebral arteries. So this patient had a vertebral artery dissection with impaired flow proximally. And then the tear in the lumen or the dissection can allow turbulent flow, so some oxygenated blood to travel past the dissection flap. Oh, I apologize. This should, oh, actually, I do remember. This is not accidental. So because we just talked about strokes with that basilar artery stroke patient, I felt like we should not just repeat that area. We'll do Washington KPI, key performance indicators for stroke. So looking at this patient, another stroke presentation for our case reviews, anybody that we suspect a CVA or a TIA, we should be getting a FAST exam, which in our county, we do a BFAST, checking a blood glucose and having less than 20 minutes scene time, which this patient had all of those done. And then if their last known normal is less than 6 hours, then having code stroke notification. Our protocol is less than 24 hours. And then percentage of the patients transferred to a designated stroke center should be on the higher end. And anybody that has a positive BFAST should also have a LAM score. So we meet and exceed the Washington KPIs for stroke. So actually, anybody have any questions, thoughts, additional for this case 3? All right. Moving on to case 4. Case 4 is a little busy, so just warning ahead of time. Case 4 is a 52-year-old male that EMS was called for shortness of breath. They found him sitting on the toilet with a lot of blood around him. He was complaining of shortness of breath. At 7 minutes, they were able to get vital signs noted to have a heart rate of 98, blood pressure 151/130, respiratory rate of 34, and a GCS of 12. They found this patient to be alert. His airway was open. He was protecting it, but they felt that there was an impending compromise because of the amount of blood coming from his mouth. He appeared ashen, diaphoretic, and warm. He had copious blood coming from his mouth from their documentation. And the past medical history provided was that he has cancer of his throat. The patient stated that he couldn't breathe. While EMS was verbally assessing the patient, he was witnessed to fall off the toilet, but he caught himself with his arms and he did not lose consciousness. This occurred at 8:37 in the morning. They initiated suction. They asked him what his pain scale was. At 6 minutes, they put him on a non-rebreather mask. At 7 minutes, they got the vital signs that I mentioned. He was hypertensive and tachypnic, unknown. Actually, what I'll say is that the reason why it's unknown for SpO2 is that they documented they had multiple issues with getting a SAT despite using a finger probe or a pediatric probe. At 8 minutes, they got an IV. At 18 minutes, they attempted a nasopharyngeal airway, which the patient would not tolerate. They decided that they would likely need to intubate this patient, but they felt that he needed to be pre-oxygenated, so they were moving forward with delayed sequence intubation from their documentation. So they administered 75 milligrams of ketamine. They documented that after administering 50 milligrams, they feel like the IV infiltrated at that point, so the patient didn't get the full amount. They tried to establish a new IV, which was unsuccessful at 21 minutes. And at 23 minutes, an iGel was placed as the patient was unconscious. At 24 minutes, an IV was established. His SATs now were recorded at 91% and an end tidal of 20. At 26 minutes, they gave what they felt was the amount that he may not have received of the ketamine, so 50 milligrams. And then at 28 minutes, they recorded another set of vital signs: heart rate 126, blood pressure 122 over 100, respiratory rate of 16, GCS of 10, SpO2 documented now at 85%, and they placed a nasopharyngeal airway successfully as the patient was unresponsive. At 36 minutes, he was given rocuronium, 50 milligrams, which is appropriate dosing despite the small amount because I think he was 56 kilos. And at 37 minutes, they suctioned him. At 38 minutes, they got another set of vital signs prior to actually attempting the intubation. Heart rate 74, blood pressure 150 over 80, respiratory rate of 12, GCS of 3, SpO2 of 99, and they were unable to place an endotracheal tube despite using videolaryngoscopy. At 39 minutes, they replaced the iGel again, and then at 41 minutes, they initiated transport. At 42 minutes, they get another set of vital signs. He's now tachycardic at 146. Blood pressure was not obtained. Respiratory rate of 15, GCS of 3, and SATs of 99%. At 44 minutes, he was given 100 milligrams of ketamine, and videolaryngoscopy with a bougie was attempted. He was successfully intubated at that point, which they also suctioned to help facilitate. And then at 48 minutes, he arrived to the hospital, tachycardic at 144, SpO2 documented 99, and he got his post-intubation pain management at 50 micrograms of fentanyl. I don't know about you guys, but when I hear about throat, tongue, larynx cancer in any patient, I want to know immediately if they're having any airway problems because these are going to be potentially very, very, very difficult airways. So I'm sure the crew that took care of this patient were potentially pretty stressed about what they might have to deal with. So in reviewing this case, I reviewed it for RSI measures, but I thought there was a lot of stuff here that would be helpful for everybody. I think that the decision for definitive airway securement was good, as the patient was short of breath, tachypnic, he couldn't get a pulse ox, and he was continuing to vomit or to spew blood copiously out of his mouth. And that's very subjective to talk about how much blood is being lost in any scene, but from the patient follow-up, I think that it was legitimately a lot of blood. I put in versus scene time because there wasn't a long transport to the hospital. So they spent about 39 minutes on scene with the patient and 7 minutes to transport this patient. But I think that ultimately that was probably, and not being on this call with the crew, that this was the right decision based off of how severe his airway compromise was. Areas for improvement, delayed sequence intubation. I think that that's reasonable to consider, but if you can't assess a patient's SpO2 reliably, you may be messing around with trying to get a pulse ox reading indefinitely. So I think that if you can't get a pulse ox, you really should not be spending a lot of time with DSI. You'll do your best effort to pre-oxygenate before intubation. But Dr. Mock may feel differently, so please feel free to open to discuss this as well. And then unless you want to say anything right now, Dr. Mock, I'll move on to the other areas for improvement.
No, I mean, I think if you can't get a functioning pulse ox, it's important to remember like the thought process behind it, which is that your best shot at a successful intubation is by getting the patient as well oxygenated as you can. And remember there are markers other than pulse ox that you can use to assess oxygenation, probably most importantly, skin signs. This is a really tough situation. You don't want to take the airway until you need to, but you also don't want to be behind. So I think if you're at the point where you're like, I need to take this airway and you don't have a reliable pulse ox, then you just do the best that you can to pre-oxygenate the patient.
Yeah. So in reading this case, I felt that I cringed personally because of the multiple attempts at airway securement. So he had 2 eye gels placed and 2 intubation attempts made. And the reason why I kind of was like, ugh, is that every time that we get into that patient's airway, we're potentially aggravating the tumor, we're potentially dislodging the tumor, we're potentially causing the bleeding to be worse, or we're distorting the anatomy that likely is already distorted by the pressure and the pressure of the eye gel placing there, and the just all of those attempts. So especially with a potentially difficult airway, multiple attempts could make it even more difficult to be successful. And then using every measure for first pass success. So the first attempt was with VL, which is great, but it wasn't until the second ET tube attempt where they used VL and bougie. And I really feel like in these patients, all patients in general, that's why we stress video laryngoscopy and bougie. We should do everything we can for first pass success, but anybody that you already have assessed as potentially being a difficult intubation, we should be set up for first pass success even more so. So that could be your cancer patients, that could be your radiation patients, that could be your burn patients, because you may not have a second attempt to get such a good view as the first attempt. And then when your IV infiltrates, you should, instead of trying to guess how much did they get or how, just give the amount that you would have given if the line didn't infiltrate. So start over. I think that prevents you from potentially under medicating that patient and trying to guess what they had or had not received. The only other thing I would say is that, I think that we use a lot of succinylcholine, and I try to point out when we should use rocuronium, but I believe this patient probably would have been better to have chosen succinylcholine, as it's a shorter acting paralytic, especially if you can't ventilate this patient. So that's all I have for the QA discussion. Dr. Mock, do you have anything else to add, or we moved on to patient follow-up?
No, I think we can move on.
All right. So in the hospital, they were able to find out that he had a history of squamous cell carcinoma of the tongue, and he recently started radiation. Because of the continued bleeding despite the ET tube, they gave him TXA, and that, interestingly enough, he had presented the day before for hemoptysis, and he was offered admission, but he decided he wanted to go home. So the hemoglobin of 5 was a 4-gram drop from the hemoglobin of 9 the day before. So they initiated irradiated blood transfusion for this patient. And then the CTA of his neck CT of his neck showed that he had a mass with active extravasation from his lingual artery. He continued to bleed, so ENT was consulted verbally. I don't believe from the documentation that they actually came down and they said that he should be transferred to a Kaiser facility as he was a Kaiser patient. So he was emergently transferred to Sunnyside. At Sunnyside, he received additional blood and he went to the IR suite for embolization of his right lingual artery. He was extubated on hospital day 3 and he was discharged on hospital day 7 on hospice. So great work in the pre-hospital setting to eventually get that ET tube, as this patient, from all intents and purposes, looks like he was not going to stop bleeding on his own. In that, as his hemoglobin continued to drop, he wasn't able to maintain his ventilations, that he would become more and more obtunded and potentially unresponsive and peri-arrest. So I thought that this was a good example of dealing with patients with upper throat cancers and some considerations. So I looked up a couple of studies. One particular study I looked at was a retrospective study of about 126 oral cancer patients and what they considered was difficult with their airway. So the presence of the oral cancer itself can obstruct your view. Anatomical changes because of the fact that the cancer may have been resected or that the patient has received radiotherapy can distort what you're looking at. The risk of bleeding is higher as this tissue is usually friable, either the cancer itself or the area that has been resected, especially if it was new. And then they also indicated that these patients could have a restricted mouth opening, either from the radiation causing some fibrosis or from pain if the patient's awake. And then their tongue may be fixated because of the cancer, so have limited ability to use your laryngoscope to identify anatomy because of tongue fixation. They may have limited neck movement, especially extension, secondary to the radiation that they've received. And it may be difficult to bag them, either because of perioral, periglottic growth from the cancer. So it is indicating that it could be essentially impossible to ventilate them with a bag valve mask, some of these patients. And that the other concern for patients with oral cancer is that the tumor is very friable, you can dislodge it and it can travel distally and become a foreign body distal airway obstruction. So how do we identify these if you don't know the patient has throat or larynx cancer? You can look at it as your lemons. So looking externally, is there scarring, either skin scarring or previous surgical incision to the neck? Is your 3, 3, and 2, if you have the time and ability to do that, is their mouth opening smaller because of the fact that there's distortion of their anatomy from fibrosis? Malampati for your M, we're probably not going to get that often in our pre-hospital setting, but also in this patient who's actively bleeding excessively. And then, so what is the preferred airway management with patients with oral cancer if we could make our setting as perfect as possible, understanding that we can't? Having enough airway support, so having additional folks, with our pre-hospital crews, we may have a couple paramedics that can be helpful, but the gold standard for patients that need airway management that have the condition of oral cancer is ideally to do awake fiber optic intubation that allows them to be breathing on their own and being able to assess essentially where the ET tube or the bougie is going to go before dropping it. Your second option would be your general endotracheal anesthesia, but definitely using a bougie, which is what we have to our wheelhouse in the pre-hospital setting. Another option in the hospital setting would be awake oral laryngoscopy, again, using the ability for them to continue to be breathing on their own, based off the fact that they may be difficult to ventilate or impossible to ventilate. And then tracheostomy or cricothyrotomy. But these are patients that rightfully so should make you uncomfortable. And like Dr. Mock had mentioned, you should be reluctant to take their airway unless it's absolutely necessary. Take their airway by placing a definitive ET tube. So as for our area's protocols, I really don't have anything that would be appropriate for this condition besides impending respiratory failure, and then we'd flip over to airway management. So I think that's all I have. Does anyone have any other thoughts, questions, considerations for the fourth case?
Just a couple of quick thoughts on that. And you think the pre-hospital management of a nightmare airway like that depends a lot on where you are, because like if you can have a quick transport and get to all the tools that are in the hospital, I think that's preferable. But then if you are in that place where you have to manage the airway, I think being ready in your mind to perform the crike, and those are cases where, like, I mean, honestly, before I intubate anyone, like I feel their cricothyroid membrane and I like think through like what's going to happen if I can't get through from above. And I think, especially with a case like that, feeling it, if you have another paramedic on scene, talking through, like, I'm going to prepare for going from above, you prepare to go from below if you need to, or knowing if you're the only one that, like, you're going to thinking how you're going to move, how you're going to get to the spot where you need to do the crike. And then the last comment on that is that in patients with throat cancer, they've often had radiation. And so the tissues of the throat can be really, really stiff. My first crike was on someone who'd had throat cancer, and like had to put a lot of elbow in it. And so just prepare yourself mentally for that. That's all.
Yeah, thank you. Yeah, I had a patient also did not need a crike, but respiratory failure with a throat cancer history, and we awake intubated him. It wasn't his first awake intubation, as it had happened multiple times before, as he continued to have acute respiratory failure. So that was, I guess that was definitely something that was nice, that he could stay awake and we could help guide him as he was sedated to be able to drop the ET tube. And for us, once we dropped the ET tube, we went ahead and just managed him like an RSI so that he wouldn't cough it out or at a reflex pull the ET tube out. But then there was another case that I've had at Peace Health where the patient had a history of like COPD and laryngeal cancer, and he came in as like a COPD exacerbation, but ultimately didn't tolerate BiPAP and became more hypercarpic. And when we went to intubate him, his airway anatomy was completely distorted, secondary to his cancer, as he had not received any treatment at his request. So having to intubate past a non-visualization of any anatomy, that was another moment of, I think, high stress. So all these procedures that we do in the pre-hospital and the hospital setting can be stressful, but even more so when things aren't going to look or appear the way that they should. So in summary, the cases we reviewed: basilar artery stroke. These are patients with posterior circulation problems of their midbrain, and they can be quite sick. Third degree heart block, recognizing that, treating it if they're symptomatic early on, recognizing that we should be pacing them. Ideally, we like a line before, but we don't necessarily have to, and remembering the dose is 2.5, not 5 of Versed. Vertebral artery dissections, these can be more common or prevalent in younger patients and can occur spontaneously or with very little trauma. And then throat cancers, laryngeal cancers, upper airway cancers. These are people that can have grossly abnormal physiology and anatomy secondary to the cancer or to the treatment that they receive. So as we talked about just recently, trying to stave off having to RSI them, as we really want to have the optimal condition to manage them in the event that they decline rapidly, but making the decision and executing it if we need to in the pre-hospital setting for RSI. That's it. Thank you.
Thanks.
Thank you, Dr. Gabois.
Yeah. Thanks, guys, for your attention.